The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. This is Dr. Dennis Birnbaum. I am a hematologist-oncologist, graduate from the University of Texas MD Anderson Hospital and Tumor Institute, and this is Cancer Update, a short walk through a long journey. Our guest today, who I'm very proud to have with us, will be Dr. Ron Scott. And to read Dr. Scott's resume or curriculum vitae could take the whole hour. But needless to say, a few points in matter here. He is the director and founder of the Wound Care Center at the Medical Center of Plano. He is also the founder of the Inpatient Wound Care Program at Plano Specialty Hospital. He is the founder and director at the Health South Plano Rehabilitation Hospital, at the Life Care Hospital of Plano, Select Specialty Hospital in Carrollton, Integra Hospital in Plano, and Regency Hospital in Carrollton. In addition to all of this, Dr. Scott is a physician engaged in a full-time practice of wound care based in Dallas and Plano, founder of the Wound Care Clinics of North Texas in 1985. He is currently serves as medical director of the Wound Care Center at the Medical Center of Plano, director emeritus at Wound Care Centers at THR, or Texas Health Presbyterian Hospitals of Plano and Dallas. He also serves as clinical professor at the University of Texas Southwestern Medical School. He's been instrumental in establishing clinical monitoring programs in wound care. And nationally, Dr. Scott served as the founding board of the Society for the Arts and Science of Wound Care. In addition to all of this, he is a graduate of Purdue University and a graduate of the University of Indiana School of Medicine. He is board certified in emergency medicine and chronic wound care. And as we get on with our program today, we will explain to you why wound care is so important in oncology patients. In addition to this, Dr. Scott himself is a cancer survivor, and he is a graduate of the SMU Law School. So Dr. Scott will be calling in momentarily. In the meantime, let me give you an update of some of the things that are happening in the news. But before I do that, let me give everybody the phone number for the Wound Care Center. I'm going to give you two phone numbers. The first number is 1-800-373-4325. You don't have to be a cancer patient to be interested in wound care, either post-op patients who have infections. You want to go to the best. You want to go to the person who developed all these wound care centers with a plethora of doctors who work for him and with him. You go see Dr. Ron Scott or his associates. The number again is 1-800-373-4325. The other number is 972-981-8658. The director there is Mr. James Hogue. The wound care centers are open from 8 to 5. They have staff members on just about every hospital in the city of Dallas, and they are excellent at what they do. If you have a call today for Dr. Scott, the number here at KAAM, the local number is 972-445-0770, and the toll-free number is 877-272-5226. Before we go on and have Dr. Scott call in, let me give you some updates from our newsprint that has come out on the weekly bulletins of Cancer in News from ASCO, the American Society for Clinical Oncology. Recent study shows fewer and this is terrible, fewer Americans, according to CBS News, are being screened for cancer. Fewer Americans are getting screened for cancer, according to a new study. It may be part of the ongoing debate between medical groups over screening harms and benefits and costs and whether or not their insurance or their businesses will pay for them. The investigators found the general public did not meet government screening recommendations for any cancer types over the past decades, except for colorectal cancer and breast cancer. It also went on to, in this article, the study found that fewer cancer survivors had screenings over the past 3 years. As you and I both know, this is absolutely necessary in order to prevent far advanced cancers from hitting us and hitting the public and being easier to be treated. Again, today we will have Dr. Ron Scott joining us. I believe he is on the phone. I'd like to tell you again about Dr. Scott. He is director and founder of the Wound Care Center at Medical Center of Plano, Plano Specialty Hospital, founder and medical director at the Presbyterian Hospital of Plano. His honors and activities are numerous, from Phi Beta Kappa in college to who's who in the National Registry. He has graduated from Purdue University and Indiana University Medical Center. He also has a law degree from Southern Methodist University. Dr. Scott.
Hey, Dennis, how are you?
I'm fine, thank you. I tried to get everybody. Let me just introduce you again. This is Dr. Ron Scott. I'm going to give the audience two phone numbers. The first one is 1-800-373-4325. And mind you, you don't need to be a cancer patient to have an interest in wound care. And the other number is 972-981-8658. And they're open from 8 to 5. Ron, thank you for joining me today.
You're welcome. Glad to be here.
Let's start right off because this could be, we could probably have 3 shows on this. In dealing with wound care, tell us, what is hyperbaric oxygen therapy, better known as HBO?
Well, first of all, we had the name HBO before the network did, so just want to make that clear. But hyperbaric oxygen therapy, simply, most people know of this when they talk about recompression chambers, scuba divers. When people used to get the bends, they'd put them in a chamber. That's the type of chamber they would put them in, a hyperbaric oxygen chamber. What they learned over the years from some of the experience of doing these treatments, they found that people with wounds that were hard to heal would go on to heal better when they used this as an adjunct or an add-on type of therapy. And in particular with cancer patients, we found in patients with delayed onset radionecrosis problems that this really, truly was one of the most beneficial things to use in conjunction with the team approach to taking care of these problems.
Why do the tissues respond abnormally after a seemingly minor injury or procedure? Is this always infection?
No. First of all, that was a common misconception about people who develop delayed radiation injuries. These are not radiation burns. Actually, these are, 6 months, sometimes years later, they'll develop a problem. And the frequent presentation of this is a patient will go in with a bad tooth. The dentist, not knowing or maybe not asking that the area had been previously irradiated for cancer, takes the tooth out, and all of a sudden there's this big hole in the inside of the mouth down to the jaw. In the past, they think, well, that's infection. It's not healing. And they give courses and courses of antibiotics, and nothing would change. But a doctor down in San Antonio at the time, Bob Marks, an oral surgeon who's now at the University of Miami in Florida, did a lot of work on this and found out from biopsies that these were really not infected wounds, but wounds that did not have a good blood supply. And what we've learned over the years is that these delayed onset radiation injuries are actually due to the loss of good blood vessels into the area. The medical term for that is obliterative endarteritis, which just means the arteries coming in are not getting enough blood flow to the area. And the other thing we're finding out more recently is that there's also this effect called a fibroatrophic effect. And that just means that we knock out the strong stem cells that are trying to come in and start the healing process up, and they can't respond like they used to. So a seemingly minor injury, taking out a tooth for a dental extraction, turns into this big, big problem. And that's why it can come on after such a seemingly minor thing.
What is delayed radiation injury or radiation necrosis, and is this the same thing as an acute radiation, quote, burn or injury?
No. Acute injuries are ones that are immediate. An overdose of radiation, somebody who would be exposed to a high dose of radiation, that would be something like radiation poisoning. Or if somebody were to get the normal course of radiation therapy and their tissues are very sensitive, maybe because of their age, they could develop a burn. But these are self-limited problems. They tend to go away on their own. What we're talking about are delayed effects that come on, so like I said, sometimes 6 months, sometimes years later.
Let me ask you, this crossed my mind. In your experience, I know when I have patients we're treating with concomitant chemotherapy and radiation therapy for increased cell kill effect, we always come into complications. And from many years ago when I was at MD Anderson, everybody tried to take care of it themselves. With the advent of wound care centers and physicians like yourself, do you recommend to most oncologists and most radiation therapists that they immediately send their patients to a wound care specialist to take care of this? And how much does it delay further therapy, giving any additional radiation or chemotherapy? And can you give radiation while you are treating them?
Okay, well, first of all, in an acute situation, a burn type of setting, that's going to be something that's self-limited, and most radiation oncologists are very adept at taking care of this on their own. However, when you start getting into these delayed problems many years after the fact, most of these people are not right in the process of receiving additional radiation therapy or chemotherapy. They're long beyond that time period. So I would say if you had a problem, if you were an oncologist or a radiation oncologist, and you were uncertain as to whether or not this might be a benefit, yes, absolutely. Seek consultation just like you would from a surgeon if you had a concern. But again, we're dealing with apples and oranges here. An acute problem versus a delayed onset problem.
Let me remind the audience, this is Dr. Ron Scott, the Wound Care Center in Dallas and Plano. His phone number is 1-800-373-4325, and his other phone number is 972-981-8658. Ron, let me ask you, how common are these injuries, and is there a dose threshold? And in your experience, is it dose related to radiation? If it's a 5-week treatment, do you usually see it by the second or third week? And is it worsened or enhanced by the use of concomitant chemotherapy?
To answer your last question, I don't think anybody really knows about any worsening effects of chemotherapy as far as these delayed onset complications. Yes, these injuries are relatively uncommon, and generally they come on usually after some sort of a small injury or an intervention like we mentioned with the dental extraction. But they're pretty uncommon. A registry, a hyperbaric registry, was set up to look at radiation injury problems, and the most recent data from 2010, I think we had 2,100 enrollees from around the country. So you can see it's not that common of a problem, but it is a problem when you have it, and it's a bad problem for some people. It is dose related. We see almost none of our patients having delayed problems when they've had a dose of less than 6,000 centigrade. When you get into the 6,000 to 7,000 range, the incidence is only 1.8%. But over 7,000, you start to get more. It's about 9 to 10% in that dose range. So if you've had a relatively low dose, it would be very, very uncommon for you to have this problem.
What triggers these injuries to start after such a latent period?
Well, again, the two effects, the lack of good blood flow from the obliterative endarteritis and knocking out these nascent stem cells that are there that should direct the healing but just don't do the job. I tell my patients it's like driving a car with no spare tire. It's a great car. You can drive it all day. Just don't go driving through glass. And that's the problem here. When you have a surgical procedure or you have a small injury of some sort in a radiated tissue field, the body just can't compensate for that new injury because of the lack of blood flow and because the cells are not reacting like they should. Hyperbarics helps reverse that problem by helping to grow in some new blood vessels to the area. And also, we know that some of these cell-to-cell signals regulated by nitric oxide are mediated by hyperbaric oxygen therapy as well.
Do all your patients undergo hyperbaric oxygen therapy?
No, absolutely not. Our wound care patients, it's probably maybe 10 or 15% at most. But certainly, if you went to a hyperbaric center anywhere in the United States in the time period of 2000 to 2012, the vast majority of these patients are probably patients that have had complications of radiation therapy.
Wow, that is interesting. What areas of the body are commonly affected or involved, and is it always radiation therapy, or can it be chemotherapy, surgery, cause and effect?
We do not see very much chemotherapy problems in the wound care centers. The one unusual one we see from time to time is when somebody has had an intravenous line with a chemotherapeutic agent maybe infiltrate under the skin and not go into the vein like it should. Those are extremely rare, though.
You mean the patient who has a Mediport?
Yes.
Okay.
Well, a Mediport, or, they use those now, but in the old days, the peripheral lines,
right,
sometimes they would do that. But that is extremely rare. Chemotherapy has advanced so much, and the nursing care has advanced so much that safety is far, far better, and it's extremely rare that we would ever see one of those. As far as other areas of the body, head and neck are number one. Jaw problems, laryngeal problems, esophageal problems, where people have had radiation in those tissue fields. But some other areas that people don't think about. Radiation for prostate cancer. We see frequently proctitis, colitis, and cystitis following those radiations. And these can be quite debilitating. People with radiation cystitis, if they're going through the standard of care and they're not improving and they're losing blood in the urine and having a lot of pain with this, we found that the hyperbaric oxygen therapy is really very useful as an adjunct for that type of radiation-induced problem.
How long is the therapy, and once they finish the therapy, do they ever have to come back, like in leukemia, you put them on maintenance therapy, do they ever have to come back for additional maintenance programs?
Well, first of all, each treatment is approximately 90 minutes to 2 hours in length, and the equivalent depth that we would add, pressure we would add, would be equivalent to being about 33 to 45 feet below sea level. That's the equivalent of 2 to 2.5 atmospheres of pressure. During that time, you're breathing 100% oxygen. But it's not a one-time thing. It's daily, Monday through Friday, just like radiation therapy, for a series typically around 30 treatments. Now, if you're going to be going in for a dental extraction and you've had previous radiation and it's in a significant amount in that tissue field, what we recommend is the patient come in and receive their first 20 treatments before the surgery to give those new blood vessels a chance to grow into the area, and then follow that up with 10 postoperative treatments. For somebody who has already developed a problem, there are staging systems, again, developed by Dr. Marks from San Antonio, on how to approach these patients. But a typical round number that most people receive is around 30 treatments.
Okay. Can these be fairly debilitating problems that occur?
Oh, absolutely. Just to use a case in point, my uncle had prostate cancer. He was radiated, and years later just had terrible, terrible problems with cystitis. And fortunately, where he lived in Indiana, he was able to go in for hyperbaric treatments. Everything else up to that point they had tried failed. And this adjunct, along with those other therapies, he was able to clear it up. Did not have any more problems. But the number one thing people complain about is pain. Typically, if it's a radiated area and the jaw is exposed, a lot of pain there, difficulty eating, difficulty drinking, and just ongoing, enduring pain, which is very, very hard on these patients.
Do you see a difference between those patients, for example, prostate cancer patients who have seeds implantable versus those who only get external radiation?
My limited series, the patients that I've seen with those problems have typically been all external, and I've not seen any with the seeds.
Okay. In dealing with head and neck cancer patients, which I see quite often, the one warning I've always gotten when I was at MD Anderson to now in practice is when you were talking about the jaw is radionecrosis of the jaw. this is the most common problem that we see with head and neck cancer. Is this, in your opinion, reversible with hyperbaric oxygen therapy?
Yes. I think following the protocols that have been outlined, these patients have every reason to believe that they can get healed. And Dr. Marks set out as his criteria for success not just closing the wound, but maintaining mandibular continuity so that you have an intact jawbone and being able to wear some sort of device, be it dentures or implants, so that you can actually use your jaw. So, that's a pretty high bar to set for himself. By doing that and by staging this in a team approach where the wound is cleaned up by the surgeons, where the hyperbaric therapy is given by the wound care specialists, where then they come in and reconstruct with the oral surgeons, doing it in this team-like approach, they've been able to get very, very good results to return these people, I think, to a much better life.
How is the delayed radiation injury treated?
Well, again, multidisciplinary teams. That's the key. If you are going to have this done and you're just going to go to one guy and he's just going to do debridement after debridement or cleaning up of dead bone and think that he can get it healed, you're probably kidding yourself. You really need to have somebody who knows what they're doing, where they can go in and stage what stage is this radionecrosis. If it's something minor, you clean it up a little bit, you give them the hyperbaric treatments, and they heal. But that's a very small percentage of the patients with this problem. Many of them do have to go on to advanced reconstructive procedures. And in that case, using the hyperbaric therapy as an adjunct has actually shown in most studies to be a very, very beneficial because you're growing in these new blood vessels into the area. Plus, you're waking up these senescent cells, making it a more normal environment for the body to heal in.
In Dallas, you and I both know that hyperbaric is not offered everywhere. A two-part question. Number one, those patients that are being treated with hyperbaric oxygen therapy, are the majority of these patients outpatients, number one? And number two, are there patients who need to be an inpatient? And if they are, how many just randomly facilities are available for hyperbaric oxygen therapy in an inpatient setting?
Okay. Well, most of the facilities are outpatient facilities. You're absolutely correct. And most of the patients that are receiving hyperbaric therapy can receive this as an outpatient. It's rare that you would have somebody that would need an inpatient setting. Even with some of the complex reconstructions, they're able to get the patients out of the hospital quickly, and they can still come to the outpatient centers. However, there are some multi-place, large walk-in type of hyperbaric chambers that are available in the Dallas-Fort Worth area for inpatients. I know Baylor downtown, Baylor University Medical Center, has a big wound care center and a large multi-place chamber where they can take care of some of their inpatients.
I want to tell the audience that this is Cancer Update, a short walk through a long journey. Our guest today is Dr. Ron Scott, probably the foremost authority that I know of, and definitely in Dallas, of wound care. His office number is 1-800-373-4325. The other phone number that he has in the Plano area is 972-981-8658. And this is KAAM. The phone number here is 972-445-0770 if you have any questions. Ron, let me go on and ask you, how does hyperbaric oxygen therapy, or HBO, work on these irradiated tissues to help with healing?
First thing that they do is actually trick the body into growing new blood vessels. If you have a wound that's in an area that's been radiated, I tell my patients it's kind of like you're aiming a bullseye at the area where you want your radiation to go. And there's a center of the bullseye where more radiation goes and it's more focused. But then as you get away from that, the outer rings of the target, a little less and a little less and a little less radiation injury. But if that radiation injury is there and it causes those blood vessels to be injured, it's kind of like getting a burr on the inside of a pipe in your house. Over time, that's where all the sludge is going to build up. Same thing can happen. Radiation might damage those little arteries out in the periphery away from where the tumor was in good tissue, And over time, that blood flow to that area is limited. It's not lost, but it's limited. And then when you get an injury in that area, you cannot respond normally. So hyperbaric oxygen therapy can actually go into these areas. And what we've seen when we've done biopsies of these areas as the healing is occurring, we're actually seeing, initially almost no blood vessels in the area, very few cells, lots of fibrosis. And then over time, 10, 15, 20 treatments, you start to see these blood vessels growing into the area. You also see more cells. Obviously, there's a better blood supply, and you can support new cell growth as well. And there's less of this fibrotic tissue in the area. So you're trying to trick the body into growing new blood vessels into an area, and then from that, the body can respond and go on to heal more normally.
As part of your team, of the wound care healing team, do all of your members include an infectious disease doctor? Who makes up your team?
Well, a typical wound care team, you're going to have your wound care specialist, and these people are drawn from any number of specialties and backgrounds. They've dedicated themselves now to doing wound care as a full-time subspecialty. Along with that, yes, we do have infectious disease consultants that we call on. Oral surgeons, very, very important in a lot of these head and neck cancer cases. Plastic and reconstructive surgeons for doing flaps and grafts in some of these areas that have been previously irradiated. Urologists and our patients with prostate cancer. Any number of general surgery background, folks that have to go in and do flaps or grafts along with our plastic surgeons. So it's a pretty diverse team. And, of course, the oncologist is always there. They're sort of the captain of the ship. That they're leading us through all this as we're trying to do all the reconstructing for the patient with cancer.
Do you ever see episodes in which you've gone through the wound care healing process and 3 or 4 months afterwards another problem arises in the previously irradiated area, that they have to go back through this similar type treatment? And in addition to that, do you personally feel that HBO absolutely works? And are there any current studies, retrospective studies that show this?
Well, first of all, there are a lot of studies out in the area of head and neck cancer. Dr. Marks and his work, seminal work that was done at Wilford Hall Air Force Base down in San Antonio. He and Dr. Johnson were the two that pioneered this area. They've continued their work on at the University of Miami in Florida. Other work, Dr. Feldmeyer and some other physicians have put together case reviews of numerous head and neck cancer patients and other types of radiation necrosis patients. And there have been, I believe, by Dr. Feldmeyer as well, some studies done that were meta-analyses of a number of other cases. And the vast majority of them show that adjunctive hyperbaric oxygen therapy does help get a higher percentage of these patients healed. And again, it's a common misconception to say, well, it's just healed, it's closed, everything's done. No, we're setting the bar a little bit higher here. Not only healed, but returned to function. Can that patient use their jaw? Can they actually eat? Do they have dentition again? Can they eat? And I believe one time I was talking to Dr. Marks, and he said to me, my definition of success is when I can take a patient out to dinner, he can eat whatever he wants, and then he pays for dinner afterwards. That's a success.
In your experience, is the response rate, the healing time, the success rate greater in the under 50 age population, and it's more difficult as you get older because of circulation and comorbidities?
Yes, comorbidities. That's the thing. Everybody, as we all get older, we have more and more problems with healing just in general. Blood vessels tend to get plugged up with time, just like using our house analogy from before. Brand new house, the pipes are clean, everything's working. But the older the house gets, the more things break down. And the same thing goes on with healing in the skin. If there's been damage to an area that's previously already, sort of running on that very, very marginal blood flow, it's going to be much more difficult to get that area to heal.
We're going to take a break in just a moment. I'm speaking with Dr. Ron G. Scott, Wound Care Healing Centers of Dallas. The phone number of Dr. Scott's office is 1-800-373-4325 and 972-981-8658. This is Cancer Update at KAAM 770 on your dial, and the number here is 972-445-0770. Please come back and join us in a couple minutes.
In 1977, in Johannesburg, South Africa, an 8-year-old boy picked up the game of golf from his father. By the age of 9, he was already outplaying him. The odds of that same boy then making it to the US and European Pro Golf Tours? 1 in 7 million. The odds of the Big Easy winning the Open Championship once and the US Open Championship twice? 1 in 780 million. The odds of this professional golfer having a child diagnosed with autism? 1 in 88. Ernie Els encourages you to learn more at autismspeaks.org/signs. Early diagnosis can make a lifetime of difference. Autism Speaks. It's time to listen. Brought to you by Autism Speaks and the Ad Council.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. You can call for an appointment at 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. This is Cancer Update, short walk through a long journey. Our guest today is Dr. Ronald Scott. He is the founder, medical director of the Wound Care Center at Presbyterian Hospital of Plano, the Wound Care Center at Medical Center of Plano, Plano Specialty Hospital, Health South Plano Rehabilitation Hospital, Life Care of Plano, Select Specialty, Regency Hospital in Carrollton, and Integra Hospital in Plano. He is also a graduate of Southern Methodist University Law School, and it has been an absolute pleasure having you here today. For the audience, Dr. Scott's phone number is 972-981-8658, and the 1-800 number is 1-800-373-4325. Ron, let us go on. How many, we were talking about hyperbaric oxygen therapy, how many treatments are usually necessary, and are more treatments needed in the cancer patient than in the non-oncologic patient?
Well, yes, more treatments are usually necessary in the cancer patient. Typically, if we're treating some other skin problem or wound healing problem, those patients tend to do really well, and we're able to return that wound to an immunocompetent state much, much quicker. But because of the damage done by radiation and these delayed effects of radiation therapy, it often takes us anywhere from 20 to 30 treatments to regrow new blood vessels. This is called angiogenesis into an area, and trying to get this angiogenesis stimulated, we go through sort of what you saw in your high school biology class. There's a lag phase where everything's getting ready, then there's a growth phase, and then it plateaus over. And that's how the body responds to the stimulus from the hyperbaric therapy. It lags a little bit over the first 3 to 5 treatments. Then between 5 and maybe 17, 18 treatments, you get that rapid growth, and then 20 to 30, it starts to bend over and plateau a little bit. And at that point, usually we're seeing the effects, the positive effects that go along with the hyperbaric therapy.
You just mentioned a word that angiogenesis. In oncology, we are now using drugs that block angiogenesis, that block this in tumor cells. Does it make it more difficult for you if a patient is on one of these drugs, like in head and neck cancers, they can be on Erbitux, or in some of the other cancers they're on Avastin, if these drugs are being used towards your healing process?
I'm so glad you asked me that, because this comes up all the time when we're talking to oncologists and surgeons. They're always asking, well, if this induces this angiogenesis, why are we using these anti-angiogenic drugs? Completely different pathways from malignant angiogenesis. So the medicines you're using to block that malignant angiogenesis, this is something different. We are literally working locally in an area where it's been previously irradiated on tissues that have this obliterative endarteritis. For example, our effect is local in the jaw area. It's not systemic. We're not going to be over somewhere that's got normal perfusion, tricking the body into growing more blood vessels in an area. That doesn't happen. What we are doing is taking these abnormal tissues and inducing what would be reparative angiogenesis, not malignant angiogenesis in those areas. So it's a common question that I get from our surgeons all the time. Why are we doing this angiogenesis if we're so worried about it? But it's something completely different, a completely different pathway.
Are there any complications or side effects that you mostly see in hyperbaric oxygen therapy?
We have some of the ones that I call the common one. The most common one is ears. People have to be able to pop their ears, just like being on an airplane. Or if you're a scuba diver, you're much more familiar with this. You're getting an increased pressure in your ears. You have to be able to yawn or swallow to get your ears to pop. And if you can't do that, sometimes you can get irritation of the middle ear and some fluid buildup there. That's probably the number one thing we see. We're able to treat that with medications and good education by our hyperbaric chamber technicians. They're very good at this and helping our patients so that they don't have that problem. But that's number one. Number two, crazy thing, it changes the shape of the lens of the eye. What they postulate is the little pumps that pump the fluid into the lens of our eye work better under hyperbaric therapy. So what ends up happening is that lens will actually change shape. Well, for some of our patients, they come out of the chamber and they say, oh, this is great, I can see much better. Unfortunately, that's a short-lived effect. It goes away when the treatments are stopped. And it's just it's one of those unusual things. We tell people, don't go out and buy new eyeglasses. This will go away. The more serious side effects relate to oxygen toxicity. Oxygen is a drug. Just like any other drug you would give, you can overdose from too much. We know what those safe limits are, and we stay well within them. But if you had too much at one time, you could potentially have a seizure. Doesn't mean you're going to have seizures the rest of your life. And the incidence of those seizures is extremely low. I've been doing hyperbaric treatments for almost 30 years. I've seen one in 30 years. So it's extremely rare. The other problem with oxygen overdose is pulmonary toxicity, lung toxicity, getting too much over a long period of time. And in our cancer patients, especially patients that have received certain chemotherapeutic agents, we want to be very, very careful in dosing the hyperbaric therapy. But again, we stay well within those safe limits so that we don't have those problems.
We have Dr. Ron Scott with us today talking about wound care. He's the founder and medical director of various wound care centers in Dallas and been on staff at various hospitals. His phone number is 1-800-373-4325, and his other number is 972-981-8658. I hate to get to the important question, which a lot of people are wondering, money. First of all, how expensive is it? Number two, is it covered by all insurances, including commercial, Medicare, Medicaid, Medicaid HMO, and do your clinics Accept all insurances.
Answer the last question first. My clinic accepts all insurances. Now, each hospital where these clinics are located has their own policies, and we are partnered with these hospitals. So it is on a hospital-by-hospital basis as to who they have contracts with. Now, having said that, back in the mid-1970s, hyperbaric oxygen therapy was going crazy. They were treating everybody and anybody with hyperbaric therapy. And a group of doctors who didn't want to see this, basically thrown out because it was a good therapy, formed a group that was called the Undersea Medical Society, later changed to the Undersea and Hyperbaric Medical Society. And in 1977, this group of physicians met and said, what do we know that it works for? What can we prove? And they put together a policy in 1977 and went to the insurers and said, look, if it's not on this list, don't pay for it. Now,
have they broadened that list?
I think they've added 2 things to it since 1977.
Okay.
And what they have done is they have said, this is where we have scientific data. This is where we have prospective, registry data showing that there's a value to this. And by doing so, being very cost-conscious, over almost 40 years ago, it's been pretty easy to get this paid for when you fit the accepted diagnostic criteria. And fortunately, delayed radiation injury, soft tissue and bony injury, osteoradionecrosis and soft tissue radionecrosis have been on the list since day one, and all these plans, commercial, Medicare, Medicaid, they follow that list. And if it's on that list, it's very, very rare that we have a problem. Usually, if we have to write an appeal, it's not a big deal because this is an accepted indication for therapy.
In either the cancer or the non-cancer patient, does hyperbaric oxygen therapy, can it cause cancer or cause an existing tumor to grow faster?
All the evidence that we have to date shows that there is a very low to no chance of this happening. And by very low, I mean next to zero. Extensive studies have been done, and they've shown in animal models and human models no new malignancies caused, and existing malignancies did not grow any faster. And again, it comes back to this. It's a different pathway for this malignant angiogenesis than what we're talking about in dealing with a wound or a area of necrosis that will not heal. They're 2 totally different things. So if I had to answer it, 100%, 0%, I can only tell you I've never seen it in my 30-year experience. I know of nobody else that has, but to say something is absolutely zero, I can't say that for sure.
I have a couple questions here from one of both of our patients. I'll just call him James, who is presently undergoing wound healing. He had a Merkel's carcinoma of the lower extremity. His first question is, what is the impact on chemotherapy when it comes to wound care's hyperbaric chamber therapy? Is this going in the opposite direction?
I think what we're dealing with there again is the angiogenic effect. And no, these are 2 different things. Angiogenesis, new blood vessel growth for wound healing, is a different pathway than angiogenesis in the malignant tumor and getting rid of that. So 2 different things. I don't think they're working at cross purposes at all.
What is the impact of chemotherapy on wound care and the use of skin grafts, all methods, to close or aid in wound healing?
Okay. Depends on the chemotherapeutic agent. Some are worse than others. There are some medications that we give that just knock wound healing down. And it makes it very, very difficult to mount an angiogenic response to prepare a wound bed for the receiving of a skin graft. Again, I tell my patients, a skin graft is like sodding your yard. The most important thing in sodding a yard is bed preparation, getting that bed ready to accept a piece of skin. If you're on a chemotherapeutic agent and you have a very, very poor or pale wound bed that has not been well prepared and the chemotherapy is knocking this down, it's going to be much more difficult to get a good healing effect from the skin graft.
In your experience, let me rephrase that. Other than dealing in the oncology area, where else, in your experience, is wound healing do you see the most of? What type of patients?
Okay. Number one, I would say patients with chronic refractory bone infections, osteomyelitis. This is not unlike our cancer patient in that chronic non-healing bone infection just doesn't have a good blood supply locally to help fight that infection, clean up the debris, and then allow the healing to occur. So that's one area where I've seen a tremendous, as an adjunct, again, it doesn't take the place of surgery. It doesn't take the place of antibiotics. It has to be used in a comprehensive approach. Another area where we're seeing this is in severe diabetic foot infections. All the recent data has shown that the chances of undergoing a major amputation for a severe foot infection with the use of adjunctive hyperbaric therapy, and the key here is adjunctive. You have to have the surgeon make sure they've got good blood vessels getting that oxygen down to the foot. You've got to make sure that you've got the right surgeon in there cleaning up any bone or infection. You've got to